So the two objectives of my short presentation would be really to update you on the presentation and disposition of patients or children who present with kidney stones. I will give you a summary of our experience with the combined stone clinic that we initiated at the Hospital for Sick Children in Toronto over the last maybe 7 years, and finish with the surgical intervention, talk briefly about retrograde intrarenal surgery and laparoendoscopic surgery. Interestingly, children sometimes may have very vague symptoms when they present with kidney stones. Sometimes they are referred with incidental findings, and they may have UTI or hematuria or blood in the urine, in addition to sometimes patients presenting with some incontinence. Most of the time, we'll actually treat them the same way you treat your adult patients. We may hospitalize them when they have obstruction, infection, intractable pain, and not tolerating PO and hydration or food. But at the same time, we rely mainly on ultrasound and KUV. And only when we have really high index of suspicion that the patient does harbor an element of kidney stones, we may consider doing a non-contrast CT. Now, in particular, the pediatric population is unique in a way that even though we know that the stones may be stuck along its path from the kidney down to the bladder, interestingly, the ureters in the pediatric population is very distensible and may sometimes actually pass larger stones than usual. Also, there is a concept that we may believe in is that pediatric population have very short ureter, and that's why maybe they will pass the stones much faster. Another fact about those population is the lower pole of the kidneys and sometimes do have a wide angle, which we call as infundibulopelvic angle, that would allow them to pass stones much easier than adult population. And unfortunately, that changes as they get older. Having said that, we know now that stones do actually pass depending on the size. And I have seen, particularly in my practice, patients who have passed stones up to 7 millimeter with medical expulsive treatment or without medical expulsive treatment. And that's why if the patient is really stable clinically, I would always suggest that we consider treating them on an outside basis. Now, as I started my short presentation, I indicated that the incidence of kidney stones have been increasing markedly over the last 25 to 30 years. And the genesis behind the combined stone clinic that we initiated a few years at the Hospital for Sick Children was mainly to really catch all those patients who were lost for follow-up. So in addition to the increased incidence, one of the things that was very much irritating to the family and made them a little less satisfied is the fact that they would come to the nephrology, be seen by the nephrologist, and a few days later they will be seen in the urology. And that's why we decided to really save money and avoid having them go for multiple visits. Another reason, as I indicated, is the loss of follow-up. We wanted to make sure that we can catch all those patients and make sure that we can actually offer them the best treatment. And we wanted to make sure that we have a metabolic profile on all of them. Unfortunately, as a urologist, as you may know, sometimes we may miss on requesting some of the elements of assessing the metabolic profile for those patients. So this combined clinic was really a very much a needed venue to make sure that we can catch all those patients with metabolic profile. I'm not going to really dwell too much on what the metabolic profile is usually done, but most of the time we do a spot urine, especially if the patient is unable to have a 24-hour urine collection, knowing that when they are in diapers, it would be very hard to do that. But if in certain cases we know that the patient may have a metabolic abnormality, we may actually consider having them be admitted for a 24-hour urine collection and make sure that we have this kind of information to guide us in our treatment options. Personally, I find this algorithm to be very helpful, and we have been using it at Sick Kids for the last 7 years. We initiated using this algorithm based on the fact that most of the time we have no standardized method to assessing patients with kidney stones and knowing what the outcome of the treatment would be. This had been very useful and have been published recently in one of the textbooks, because we find that if we actually initiate using it in the emergency room, we will be able to really identify the patient or can get a sense of where the patient is going to be ending up at the end. Now, I'm going to give you a short summary of the outcome of that clinic. And the short-term outcome of that clinic was immense to some extent. I would say that the saving was very much high. We were able to really make sure that we tailor the treatment and the imaging studies for this population in a very good way. The parental and the patient satisfaction was quite high. We were able to really select the right patients for the right surgical intervention, and we were able to identify the metabolic profile behind most of the kidney stones pathology. We had way less follow-up than what we used to have prior to the combined clinic. Having said that, it's always important to really get a long-term outcome. And one of the things that most of you would know is the fact that we actually do see patients and treat patients way different than an internist or even a nephrologist. So the clinic that I usually would be able to run for 25 or 30 patients between 8 and 2 o'clock was become completely less efficient, because nephrology most of the time would take at least 45-minute time with the patient rather than 15 minutes as a surgical consult. That really blocked my productivity in the clinic and did not allow us to be able to see more patients. But at the same time, there were a few things that we really did realize that there is a bit of a disagreement between us and the nephrology. One of the things is that we had very minimal role as urologists in the medical intervention for the patients with kidney stones in the pediatric population. We really didn't have too much input. Most of the time, the nephrologist will be the one to decide on what kind of medical treatment the patient will be on. We did agree that hydration is very important. We actually did suggest to some of the parents to sometimes wake up those patients and those children at night to give them some fluid if need be. We did not agree on the type of analgesia we wanted to give our patients. Unfortunately, nephrologists, or fortunately maybe, they are very keen to avoid any non-steroidal anti-inflammatory medications, and we as urologists, we consider that as the main treatment for patients with kidney stones sometimes. We had questions about the value of alpha blockers, and again, because we were able to really funnel all those patients into one single clinic, we were able to see that sometimes patients who have been asked to start on alpha blockers did not really have a good outcome or a better outcome than what we anticipated before. When we looked at the number of patients, we found out that 75% of our patients had calcium oxalate or calcium phosphate. Sometimes we did not have any predisposing factor. There was no metabolic abnormality whatsoever, and it was only present as abnormal findings in about 75%. When we had patients with struvite stones, we always considered those patients to be needing urgent antibiotic intervention and surgical intervention. And the majority of those patients, by the way, did have some form of an obstruction in their kidneys, and we were able to really treat both pathologies, the stone and the obstruction at the same time. Uric acid stones, I have noticed actually since we had the stone clinic that our team, our colleagues in the oncology team had been very much more proactive in avoiding having uric acid stone in their population, and they have been very well prepared to make sure that their patients are well hydrated. They are being given all the precaution to avoid having any of the uric acid stones. I personally consider the cystine stones in the pediatric population to be the most burdening pathology, and unfortunately those patients really don't only need multiple interventions, but they also have a major issue with the compliance with the different medications that we usually give them. And that constitutes the largest number of patients who needed multiple recurrent interventions in the operating room, whether it's retrograde intrarenal surgery, percutaneous nephrolithotripsy, or even laparoendoscopic surgery. I'm going to spend the rest of this presentation to really briefly talk about the type of surgery we offer our population. Now, understandably, ESWL is not really a true surgery, but ESWL had been used extensively in the pediatric population. I would say that the size of the stone should be 1.5 centimeter to less. I would say that also the fact that you need to put the patient under anesthesia is a big issue, and you need to take it into account when you're treating a very young patient. And most importantly, whether you want to put a stent or not is very much important and need to be discussed with the family, because if you break a stone that is in a non-invasive manner, most probably that patient will end up being in the emergency room a few days afterwards with Steinstrasse, and sometimes you may need to admit them. The stone-to-skin distance had been a very interesting topic for us at the time when I used to do ESWL, and I found that there's no value of measuring the stone to the skin distance, and I think most of the patients, even if they are obese, the lithotripsy had been very efficient. The percutaneous nephrolithotripsy, as it is indicated in the adult population, is for the stones which are more than 2 centimeters. But one of the things that at least I experience at Sick Kids is the fact that, unfortunately, because we don't do our own access as in London and in other places, we had to rely on the radiologists to be able to get us access. And unfortunately, sometimes they would get us the wrong access, and that would limit our ability to really do what we needed to do in terms of percutaneous approach. Another thing that was of a major issue is the amount of radiation our population had been getting. And again, a LARA concept is really very important, especially when you have one of the trainees or even the radiologist or myself, even at the beginning of my practice, having my foot on the pedal and keeping on doing x-rays for a patient who has large ratio of multiplying cells, which we know now that the radiation impact on pediatric population is, by the way, a bit worse than radiation impact on adult population. So for that reason, I would say that, again, since we introduced the concept of a combined clinic, we have been using more and more retrograde intrarenal surgery, and we have been offering laparoscopic surgery for patients with kidney stones. And I think with the miniaturization of the instruments and with less radiation, I would hopefully would be able to convince some of the people who are treating kidney stones in pediatric to incorporate RIRS into their practice. So really, when I'm asking what's the most effective and least morbid treatment, I always say that it depends on multiple other factors. If you have the right instruments, if you really go by the LARA concept, if you know what the number of procedures you have performed before, and you have the overall morbidity for each patient, then you can really individualize your treatment option. For instance, this is a patient who is a spina bifida patient who could not be even put in the lithotomy position. We had to find a way to actually put her legs up to be able to get up to the kidney stones. This is a patient that most probably would be better treated with percutaneous nephrolithotripsy. Unfortunately, with her scoliosis and with her spine pathology, the radiologist was not able to confirm to me that he will be able to get the right access for me. So this patient was multiply treated with RIRS. And again, the miniaturization of the instruments really make RIRS a bit more attractive, in addition to the fact that you're using less radiation. And the patients usually will be accessed the same way you would access an adult patient. We put 2 guide wires, and if you have really the dual lumen urethral catheter, it will give you an opportunity to have the 2 catheters in. Here we're actually operating in one of the radiology suite, and I have a radiologist available with me because sometimes if we find that the kidney stone is too big and we are not sure that we will be able to clear it with 1 or 2 ureteroscopies, we will be able to get the radiologist to have access through a percutaneous approach while guiding him intracorporeally. We use usually semi-rigid ureteroscopes. We actually make sure that the access to the urethral orifice is gently approached. Otherwise, we really have some issues with some of the forceful ureteroscope introduction. One of the things that I always suggest for the novices in pediatric urology and who do treat patients with kidney stones is to make sure that they would not rely on the high pressure irrigation. I would suggest that they would use 20 or 60 cc syringe that's connected to the ureteroscope, and then you will be able to get your assistant to really help you to open the ureteral orifice if you need to, and irrigate the ureter under guidance and on command, rather than have the irrigation be at all times producing high pressure or inducing high pressure into the system. And most of the time, I tell people, if you're really unsuccessful in getting into the ureteral orifice, do not really panic and worry too much. You can do the stage ureteroscopy where you can put a double J and come back at another time. The physiological narrowing in the ureter is a known fact, even in the adult urology. I would find that sometimes just putting my hand on the abdomen and straightening the ureter, it might actually help you to get through the narrow part of the ureter. And again, dilating the ureter with minimal pressure is very useful, and this is why I like to use the syringe rather than use the pressure that you sometimes actually forget in a long case what's the pressure in the bag, and you end up having a bit of extravasation even without the presence of perforations. Most of the time, if you have a stone or you have a clot, it would be good to be able to get it out. I find that sometimes having a bit of distilled water available might be allowing you to really lyse the red blood cells. I don't find that to be very useful as much as having a bit of contrast sometimes, or mineral oil. And the reason is because different density between the contrast and the water would allow the contrast to come down and will give you better visualization, even if you're not going to be using the X-ray or the fluoroscopy. The ureteral sheath had been a bit of an issue even in the adult literature because there is a report of high incidence of ureteral injury, even though when you look at the numbers, it's actually not as high as was reported initially. But we had some cases where we ended up having an injury at the distal part of the ureteral sheath because of the frequent introduction of the ureteroscope and getting into the ureteral wall and causing some abrasion there. So the one reason why I feel like the ureteral sheath is very important is because you don't want the bladder to be full and not be able to really complete your surgery, or whenever you have a decreased visualization, most probably the bladder is full and you're not getting good irrigation. So in a very young children, in a girl, what I usually do, when I put the ureteroscope into the kidney, I put a 6 or 8 or 10 French feeding tube next to the ureteroscope in the bladder. That would allow the bladder to be always draining as you're proceeding with your surgery. In boys, unfortunately, you may not be able to put a catheter along the ureteroscope. So what I usually do is I take a large bore angiocath and I put it suprapubically and I connect it to a large syringe. And every now and then I will have my assistant, or I will do that for my assistant, and I empty the bladder. Emptying the bladder routinely is a must when you're doing retrograde surgery, and that's why I think it's very important to make sure that you have a plan when you're doing retrograde intrauterine surgery. And again, the pressure bags are unique and important, and especially you need to warm the water the water when you're using it, or the fluid when you're using it. More importantly, I favor the 20 or 60 cc syringe because it will give you irrigation on command, and you will be able to really make sure that you do it the right way. Unfortunately, I have some extravasation in few cases when the fellow who was assisting me wanted to be so nice and he kept on pushing too much under a lot of pressure, and you need to make sure that your assistant is not doing that frequently, otherwise the micro perforations may happen or extravasation may happen. Most of the time, getting the stones out, as I said, or getting any difficulty in visualization, you may be able to use saline or you may use contrast. The many leaks I just mentioned are sometimes common, and that's why I think it would be important once you finish the procedure to just do one shot of retrograde to confirm that you're fine and you're happy. In very small number of cases, if I clear the whole ureter or the upper tract from the stones, I will still do a retrograde to make sure that I don't have any extravasation, because if I am happy without leaving a stent, I may leave the patient without a stent and I will just get them sent home the same day. And if for any reason you have a bit of a leak or you don't feel comfortable that the ureter is abrased or injured somehow, I think a stent will be the best way to do it. And long procedures, as I indicated before, if I know that the procedure for a kidney stone is going to need multiple ureteroscopies and I may need a percutaneous nephrolithotripsy, then I will get the radiologist available and we will do a perc under vision, as I indicated. So while you're into the kidney, you basically go into the pole that you want to be getting access to, and you will see if the radiologist with ultrasound guidance will put the needle in and help you get it. This is one of most favorite study for me to always quote from Turkey, showing that when you do retrograde intrarenal surgery and compare it to percutaneous nephrolithotripsy, the amount of radiation is way less in retrograde intrarenal surgery. And there are few reports coming out now showing that you can actually do retrograde intrarenal surgery with no radiation whatsoever. I have not yet been able to do that personally, but I think that might be the future to some extent. I'm not sure what kind of imaging they are doing, but I have been reviewing some papers indicating that they were able to do some of that surgery without any radiation. Again, I could only solve the idea on the retrograde intrarenal surgery with the fact that the stones should be to some extent 2 centimeters, but more than 2 centimeters or 2.5 centimeters would not be amenable for this technique whatsoever. The last approach I really would like to just bring forward is the fact that some of those patients, especially in the pediatric population, when the family refuses to have more aggressive interventions such as PCNL, and again, the PCNL, if it's not going to be 100% successful in getting you the best location, then I usually offer to the family a laparoendoscopic surgery. Laparoendoscopic surgery is really possibly the best way I find it for patients who we know that have idiopathic stones, who may have a low chance of recurrence if there is, I'm not sure why the video is not working though. So here in this particular patient, what we have done is we have done a retrograde at the beginning of the procedure. We put a stent in, and then I dismembered the pelvis, and I went in and identified the stones in the pelvis, removed them. And once we could not get into the upper pole or the lower pole, what we have used is one of the nephroscopes through one of the trocar sites. And then we went in, and while opening the pelvis, you can go in with the nephroscope, and you can really go into each and every pole of that kidney and identify the stones and remove them. Now, if you have a guarantee that you're not leaving behind any small stones, that would be the best way of doing it. If you're really not sure, then what I usually do is before I finish the procedure, I make sure that I put a percutaneous nephrostomy tube for this patient, close the pelvis or approximate the pelvis to the ureter, and then later on do a nephrostogram for the patient and confirm that I don't have any stones remaining. In this particular patient, as I indicated, we ended up doing a pyeloplasty for the patient since we dismembered the pelvis and we spatulated the ureter and approximated the ureter to the pelvis. So really, in conclusion, I think the management of stones in general, in pediatric population, will follow the same guidelines as you would use for adult cases. I would say that you need to be very much targeting the patient on an individual basis in a way, so you need to make sure that you can do PCNL if you have the skills to do that. You have to really look at the location and identify the burden of the stone and decide on what kind of an intervention you need to do. I still think that RIRS and laparoendoscopic approaches could be very much useful, particularly in the pediatric population. The one thing that I really need to bring forward is the fact that RIRS is, by the way, is not cheap modality whatsoever. It's actually very expensive, and sometimes when you go into the operating room after a long case of retrograde intrarenal surgery, you will find a number of gadgets that have been opened are worth thousands of dollars, and that's why you need to be very cognizant about that. I think what's unique about the children on the other side is that the fact that they are highly prone for recurrence, and there's nothing that we call as non-significant residual kidney stones in pediatric population. We published that almost 20 years ago, and we showed that there is nothing that's non-clinically significant. Any residual stone in a pediatric population may come back with recurrence. I think it's very important, more in pediatric than in adult even, to consider having a multidisciplinary approach. And what I mean by this is that a nephrologist should be part and parcel of your treatment options. And more important is to have a dietitian available for the consult for this family, because if you're going to really limit the amount of diets that is going to be on, you may have an impact on their growth. And it's well known that if they have a metabolic profile that's abnormal, then they will need to really be cognizant about that. I personally am very much pro for suggesting minimal invasive approaches for any form of kidney stones. And there's no question PCNL is a minimal invasive approach, but unfortunately with it coupled with the imaging, there is an impact of radiation in the pediatric population, and that's why I'm more vocal about the fact that you may need to really consider other approaches such as laparoendoscopic approach and retrograde intrarenal surgery. I want to thank you again for the invite, and it's good to see friends here. Thank you.